Yes, sir.
Okay. Good afternoon, ladies and gentlemen. It's a pleasure to be here today to present this topic to us. And what we are doing today is to mark the World Diabetes Day, which falls exactly today. So, in my own talk, I'll be talking about integrating diabetes care into daily work routines. My name is Dr. Akinlade. I work at the General Hospital, Lagos, Oda. So these are my learning objectives. And so we'll start by looking at what diabetes is. We know it's a metabolic disorder that's characterized by chronic hyperglycemia. And this hyperglycemia usually results from defects in insulin secretion, insulin action, or both. Meaning in people who have diabetes, is either they are not producing insulin at all, or they are not producing enough, or even when they produce enough, there is a problem with the insulin action at the site where the insulin is required. So there are several types of diabetes mellitus. The more common ones that we know are the type 1, type 2, and the gestational diabetes. In type 1 diabetes, there's absolute deficiency of insulin secretion, whereas in the type 2, the main problem is beta cell dysfunction leading to inadequate insulin production and insulin resistance. The bulk of the diabetic patients are actually type 2 patients. And then you also have another class called the gestational diabetes. And this is usually diagnosed during pregnancy. It's usually a diagnosis of exclusion in the sense that you can only be sure that what the person had was gestational diabetes if after the person delivers and the blood sugar returns back to normal and the person does not need to continue treatment. Because sometimes type 2 or type 1 can develop during pregnancy. Those patients, after delivery, the blood sugar will remain high and they will need to continue to take anti-diabetic medications. So diabetes can also be caused by some other specific problems. For example, it could be genetic, and that's when you have some conditions that we call the maturity onset diabetes of the young. It can also be seen in neonatal diabetes. People who have diseases of the exocrine pancreas, for example, chronic pancreatitis, cystic fibrosis, can also develop hyperglycemia and, in effect, diabetes mellitus. So also people who have abused steroids over a long period of time, patients who are on treatment for HIV, for example, now we see a lot of patients who are on dolutegravir coming down with diabetes, or even after organ transplantation because of the high steroid doses that will be used to prevent transplant rejection. So these other cases can also result in diabetes. So what about the global burden? We all know the prevalence is increasing all over the world. We have about 600 million people now with diabetes all over the world. And we also are aware that about 300 million people even have diabetes now and they are not yet diagnosed. And a large number of people have pre-diabetes and they go about until they develop complications and they present to the hospital. And the numbers are expected to rise. In the next 25 years, the projection is that we have about 850 million people globally having diabetes. Diabetes kills more people than tuberculosis and HIV combined. So it's a very serious ailment. And when you look at this slide, you will see that all over the world, the prevalence will increase in the next 25 years. But the largest increase will come from Africa, meaning that Nigeria should also brace up for a high prevalence of diabetes, being the largest in terms of population in Africa. So we know that 1 in 9 adults are diabetic at this time. 1 in 8 adults have impaired glucose tolerance. 1 in 4 people who are over 65 have diabetes. So, and 3.4 million people died from diabetes at the end of 2024. A majority of patients who have diabetes will be in the low and medium or middle income countries of the world. So in Nigeria or in Africa, currently we have about 25 million people with diabetes. And the number is expected to rise to about 60 million in about 25 years' time. In Nigeria, the estimate, even though the estimate by IDF was 3%, which translates to about 3 million. But there have been a meta-analysis that was done recently by my colleague, Professor Olamoyigun, that showed that the prevalence may even be as high as 6%, meaning that we have about 6 million Nigerians who have diabetes currently. In terms of how diabetes develops, we know there are multiple complex pathophysiological abnormalities in patients who have type 2 diabetes. It is not just about the fact that the pancreatic beta cells are not producing enough insulin. We are also aware that patients who have diabetes have increased hepatic glucose production. Their liver is churning out a whole lot of glucose, whether they eat or they don't eat. Their fats, their proteins are broken down to produce a lot of glucose. Their kidneys are also working overtime, in overdrive, to reabsorb a lot of glucose in the proximal convoluted tubule. We also know that as they have reduced insulin production, they also have increased glucagon secretion. And glucagon is gluconeogenic. Glucagon promotes the breakdown of fats, the breakdown of proteins to produce more glucose. Our guts also has a role to play in us developing diabetes. There's the hormone that we call incretin that helps the beta cells to produce insulin after we have eaten. But in diabetic patients, we know that they have less of these hormones being produced, meaning that not enough insulin will be produced by the body. We are also aware that insulin resistance prevents the movement of glucose into the skeletal muscles as well as the adipose tissues. And these are sites where insulin are broken down to produce energy. So this is the scenario in a typical diabetic patient. Multiple abnormalities exist to produce the high blood glucose that we see in them. But the good thing is that we have medications that can improve all of these abnormalities that I've stated here today in managing them. So our patients are better managed than they were several years ago when we didn't have this knowledge about diabetes. One of the other things that we now know about diabetes is that when you diagnose them, that is not when their diabetes started. It is a progression that started nothing less than 5-10 years before that date that they are diagnosed. such that by the time they are diagnosed, 50% of their beta cell mass is already gone. And when they are not managed well over time after their diagnosis, you also notice that the beta cell function will decrease rapidly, such that someone who normally should have been a type 2 diabetic patient will rapidly progress to one needing both oral medications and insulin to maintain adequate control, because the beta cell function has reduced so much that that patient now has a picture of someone who has type 1 diabetes. In terms of the natural history of diabetes, like I told you, it starts very early, many years before the diagnosis is made. Anybody who has a family history of diabetes, anybody who is overweight, anybody who has hypertension, anybody who has sedentary lifestyle is already on the road to diabetes, because such people, they tend to have insulin resistance. And this insulin resistance continues to increase. And as insulin resistance increases, it means that the pancreatic beta cells are forced to produce more insulin. But after a while, the pancreatic beta cells is not able to cope. And then you now see the insulin production gradually going down because of decrease in the beta cell function, such that by the time that patient is diagnosed, like I said, 50% of the beta cell function is already gone. And if you look at this graph, the one in pink, that is the fasting blood sugar. The one is, I don't know, this one looks like red to me. The other one that is pink is the post-meal blood glucose. It's usually the post-meal blood glucose that starts to rise first, even before the fasting blood sugar. And that's why when you rely on measuring the fasting blood sugar alone to diagnose your diabetic patient, you will miss someone who is already diabetic for several years. And because of that, many of them will present much earlier with complications. So we always advise that when you want to diagnose diabetes, it's better you do an oral glucose tolerance test, which will show you the postprandial blood glucose state as well as the fasting blood glucose state. So these are some of the factors that contribute to the damage to the beta cells in diabetic patients. High blood sugar level is toxic to the beta cells. The lipotoxicity, because the fat cells are broken down, also toxic to the beta cells. And over time, inflammatory cells also come into play, and they also damage the beta cells. And you can then also start to have amyloid deposition. And all of this will cause apoptosis of the beta cells, leading to a decrease in insulin production over time. So these are the risk factors for type 2 diabetes. I've already mentioned some of them. Apart from the age, anybody who is 35 and above is at a risk. The fact that we are blacks puts us at a higher risk. If you are beginning to develop pot bellies, if you are overweight or obese, anybody who has had multiple pregnancies, anybody who has delivered a baby weighing 4 kg or above, or any woman who has had gestational diabetes is likely to develop diabetes later in life. And people who are physically inactive, sedentary lifestyle, patients who drink alcohol, who have cholesterol problem, hypertension, anybody who has been diagnosed to have pre-diabetes may eventually go on to develop diabetes itself. Anyone who has had a history of gestational diabetes will eventually develop diabetes. So also people with polycystic ovary disease, acanthosis nigricans, which is a marker of insulin resistance. So anyone with a psychiatric illness like schizophrenia is at a risk of, of developing diabetes. So how is diabetes diagnosed? The criteria for diagnosis are been standardized such that with your glucometer, you can make a diagnosis. But the standard test for making diagnosis is by doing the oral glucose tolerance test, where the patient, after checking the fasting blood glucose, the person is given a standardized glucose drink, which is 75 grams of glucose. And then when you check the blood glucose 2 hours later, if it meets the criteria on the screen, fasting of more than 126 milligrams or 2 hours post glucose load of 200 milligrams and above, that person is diabetic. Or you do the HbA1c in addition to either of these fasting or 2-hour postprandial blood glucose level. And if the A1c is already more than 6.5, then the person can be diagnosed as having diabetes. So, but if someone has symptoms and you do the random blood glucose, even with the glucometer, without doing the OGTT, and if it's already more than 200, that person is diabetic. Or someone who has symptoms, is peeing a lot, is thirsty, is having blurry vision, and all of that, and you check the fasting is more than 126, that person is diabetic. What about pre-diabetes? Pre-diabetes is when you have what we call impaired fasting glucose or impaired glucose tolerance. When we say impaired fasting glucose, we mean that fasting blood glucose level is already between 100 and 125, but it's less than 126. Anybody who falls within this range has impaired fasting glucose, which is called pre-diabetes. Or when you do the OGTT and the blood glucose is between 140 and 200, or 140 and 199, such a person already has impaired glucose. To the A1C, and the A1C is already between 5.7 and 6.4. Such person has impaired glucose tolerance, and that person can be diagnosed to have pre-diabetes. We don't take pre-diabetes as who has pre-diabetes can develop all the complications of diabetes itself. So we take it as seriously as someone who has diabetes. So having said all of this, now we can go on to talk about the unique challenges to diabetes self-management that are faced by working individuals, which is the theme of this year's World Diabetes Day. So let's look at the modern workplace and diabetes management. What are the conflicts? There are work demands such as fixed schedules. You have several deadlines, long meetings. Patient has to commute from very far distance to work. As a result of this, it disrupts their regular monitoring of their blood glucose. Some of them are not able to take their medications as at when due, and they're also not able to take their meals as at when due. They have little or no space for physical activity, and as a result of this, they develop stress. It affects their mental well-being, and all of these can also become a vicious cycle that may continue to affect their glucose monitoring, in the use of their medications, as well as their meals. And the consequences of all this is that many of them may now start developing It's either they are taking their medications too much and then they are developing hypoglycemia, or they are not able to take their medications as at when due, and then they have hyperglycemia. Because of these, some of them fall sick very often, and then they are also exposed to increased risk of complications of some of the complications of diabetes. All of these contribute to what we call diabetes distress, and can affect their productivity and reduce their psychological well-being, and may even lead to burnout. So then our role as healthcare practitioners, the doctors, the nurses, the dietitians, the pharmacists, is that we have to help them bridge this gap. And we have to do this with empathy, and we have to formulate realistic strategies with them, looking at their work schedule, so that it can make it easy for them to monitor their blood glucose, to take their blood medications as at when due, and then to take their meals also, and also fashion appropriate physical activities for them that will not disrupt their work, and at the same time will help them continue to remain fit and help them manage their stress. So some of the things that we can do to help them at work, for example, let's look at medication adherence, for example. The challenges are they may forget their doses. Some of them may feel embarrassed taking their medications before their colleagues. And because of the kind of schedule that they have, it may also affect their meal time, their opportunities to exercise, and all of that. So, but what are the practical strategies that we can devise that can help them overcome these challenges that we have highlighted? Because for them not to forget their doses, we can encourage them to use technology by setting alarms. They can get smart pill boxes where they will have put their medications, and they can easily reach to and take their medications even while they are at work. Once the alarm on their phone sound, they know that it's time to take their medications, and then this will help them from forgetting their doses. And then they can also link all of the taking of their medications to their routines. For example, we may ask them that when you are taking your first coffee break, or when you are going for your lunch break, please take your medicine at that time. Or as you get to the office, you know that the first thing before you plunge yourself into today's work, first thing you should do is take your medication. And the pharmacists and the nurses, we all have a role to play in this. We should encourage fixed dose combination to reduce pill burdens. And then where we have long-acting formulations, for example, now we have medications that some patients who can afford it can use just once a week to better manage their diabetes. We can encourage them to go for those ones so that there will be less disruption with their work. And then in terms of counseling on the fear of being seen, the nurses can come in here and help provide practical counseling on how they can overcome the fear of being seen at work. So the second pillar in helping them to adjust their diabetes control to their work environment is in terms of their glucose monitoring. Some of them, they perceive the checking of their blood glucose as destructive, as time-consuming, and then because some of the offices, they don't have the privacy, some of them may not want to check their blood sugar when everybody is looking at them. So, and we have to help plan a strategy or strategies that can help them overcome these challenges. For example, we can help them plan their checks around their break times, for example, when they are going for their lunch, or they can also check after their lunch. We can advocate for less invasive continuous blood glucose monitors, which is very effective, except that it's very expensive in this part of our world. But where it is affordable, they only put on the continuous blood glucose patch and then use their smartphone to scan. And it gives them their real-time blood glucose level. That one, they are not bringing out their meters and pricking themselves before everybody. Well, if this is not practicable and they still need to use their meters in the office, they can come to the office with the meters in a small pouch where they already have their strips, their lancets, and then they can just go into their restroom, check their blood glucose, and come back to their desk. So this can also help them to overcome the lack of privacy that may not make them to check their blood glucose while everybody is around. And then we also have to sit with them and get to let them know what time of the day they may need to check their blood glucose. Maybe before they are leaving the house, and then also when they get home in the evening before they go to bed, if it is not possible for them to check it during the day. In terms of nutrition as well as hydration at work, the challenge is that many people at work will rely on their canteen or cafeteria food. Some of them may need to use the vending machines and sugary snacks from colleagues, and then they tend to have irregular meal times. Those are the challenges here. So how can we overcome these challenges? We can encourage them to pack their meals from home if they are able to do that. And then we can also help them to understand the menus in their cafeteria. And if possible, discussing with their cafeteria to provide better meal choices for them. And then we should encourage them to keep a bottle of water at their desk and ensure that they drink a lot of water over the course of the day. And they should limit sugary snacks or sugary drinks. Because the nurse, the dietitian, as well as the pharmacist also have a role to play in this regard by providing simple visual guides on their portion size, as well as the healthy snacks swaps that they can take during the day. So the other part is integrating physical activity, because many of these patients, because of the nature of their jobs, they are behind their desks, some of them from morning till evening. So it might be difficult for them to have the regular 30 minutes or 15 to 30 minutes exercise every day. But for me, the practical thing I tell my patient, the first thing I ask them, your office is on what floor? If he tells me my office is on the 5th floor, I encourage them to use the stairs instead of taking the lifts. You can start with maybe 1 floor, 2 floors, and then as your exercise tolerance improves, you increase the number of stairs that you have to take. And once they are able to do this every day, they are already meeting their exercise requirement. I also ask them to set their alarm so that every 2 hours they get up from their seats and at least walk around and come back again. Some of them, I encourage them to get up from their seat, stretch their calves, roll their shoulders. At least every 2 hours, I tell my patients to do this. And when they are coming or when they are going back home, they should drop at least a bus stop from their home so that they can walk down and also get some exercises. So the overarching pillar is that we want to help them with their mental stress, mental well-being, and we also want to help them with their stress management. The challenges at work is the pressure, the diabetes, the stress that can result from the thinking that I'm not doing well with my diabetes, my work is not allowing me to take my medications as at when due, I have no opportunity of eating the kind of meals I want. It can be very stressful. And of course, they also have at the back of their mind that my sugar is not doing well. I'm exposed to developing complications. So all of this can be very stressful for a diabetic patient. So, and the strategies for this, we can ask them to take small breaks, 2 minute breaks to do breathing exercises. They take in deep breath, hold it for 5 seconds, breathe out through your mouth. Do this continuously for like 2 minutes. And they can make use of mindfulness apps, which can help them to um, manage their stress at work. And then we should also encourage our patients to have an open conversation with a trusted colleague or even the HR. The HR should at least understand the kind of patient and then give them some leeway to, because some of them may be like, why are you getting up so often from your seat? Because the person does not understand. So if the patient can go meet the will understand their predicament and may be open to help them manage their diabetes better. So as HCPs acting as a coach, we should not just ask, what are your numbers? But we should also be asking our patients, how is your work affecting your diabetes? Because it is when we do this that we'll be able to understand what they are going through and then able to help them plan not only their drug intake, even the checking of their blood sugars, even their follow-up, their exercises. And when we show this kind of understanding and empathy, then they are happier, they are less distressed, and they are better able to manage their diabetes. So this is like a case study to show us how we can practicalize all that we've been talking about so far. The patient is Mr. Tunde, who is a banker, who has had type 2 diabetes. He has to travel from Ikorodu to the island every morning. And when he gets to work, he jumps into a meeting. He eats from the canteen. He has little or no time to check his blood sugar. He's always feeling tired. He's behind his desk. He has little or no time to exercise. And at his last check, the A1C is rising. So how can we help them as doctors, as pharmacists, as dietitians? We all have a role in helping Mr. Tunde to manage his diabetes while at work. As a physician, my role is to provide simplified medications. The medications must not be too complex for Mr. Tunde if I want him to be adherent to his medications. It's better I give him a medication that he takes twice a day that will align with his morning and evening commute. And as a pharmacist, can help him get a weekly pill box where he puts all his medications, and is able to reach the medications easily. And then the dietitian comes in to advise on the healthy canteen choices, and if possible, bring his packed meals from home. And the nurse also comes in to help him check his blood glucose within 2 minutes, even before he goes in for his meetings, and then how he can get out a 10-minute walk from his very busy schedule. And overall, if you are able to do this, you will be able to improve his glycemic control, reduce his stress, and better his mental well-being. So The role of healthcare professionals as advocates is that for the individual patients, we want to help create individualized, there's no general plan. Whatever plan we are creating for a patient must be individualized, must be tailored to the routine and the work pattern of that particular patient. All right. So, and we must do this by listening on understanding how the patient works in a day and some of the specific challenges that the person has when we are consulting with them. And in the workplace, as nurses and pharmacists, we can offer workplace wellness talks on diabetes awareness. And for us as doctors, we can provide medical advice to corporate organizations on creating diabetes-friendly workplace. For example, ensuring that the canteen or the cafeteria has healthy food options. And then we must also have flexible break times. I know of a company that ensures that in the morning when their staff resume work, especially they do it once a week, they shut down the lifts and forces everyone to climb the stairs. That way, at least they are getting to exercise. So we can also talk to those companies to do the same for their staff. It's better to do this at least like 3 times in a week. The lift is shut down, everybody is forced to walk. I know of a pharmaceutical company in this Lagos that has a gym within their office space. And at certain times, they force their staff to go exercise. And all of these will help to destigmatize diabetes in the workplace and improve their workers' well-being. So the key takeaways from this talk is that diabetes management doesn't stop at the office door. A practical pillar-based approach is very effective, like we have highlighted. And when we offer advice to these patients, the advice must be empathetic. We should not be issuing instructions to them. We should talk to them based on what they are actually going through. And so that whatever we're advising or counseling them must be realistic and must be tailored to their professional life. All right. As healthcare teams, we are very crucial in equipping these patients with the tools and confidence to manage their diabetes seamlessly throughout their workday. By doing this, of course, we'll be helping them to better manage their diabetes at their workplace. So I thank you all for listening. I'll take questions when we're done. Thank you, everyone.
Thank you so much, Dr. Akinlade. That was very insightful and very timely. Thank you so much for the lessons around adherence, convenient blood glucose monitoring, and also nutrition. Can we give Dr. Akinlade a virtual round of applause? Thank you very much, sir. Okay, very quickly, before we move on to the question and answer segment, I'd like to invite our second speaker for today. Dr. Dr. Modupe Oyawole, FAMD, FPC Farm, FPSN, FNE Farm. She's a seasoned consultant clinical pharmacist at Lagos State University Teaching Hospital, LASUT. Dr. Oyawole care, antimicrobial stewardship, and chronic disease management. With a career spanning over 2 decades, she has pioneered patient-centered initiatives, including multidisciplinary ward rounds and adherence counseling programs, significantly improving outcomes in diabetes and renal care. She excels in ambulatory care through development of patient counseling programs in diabetic clinics to improve medication adherence and carefully ensures management on chronic disease management, including diabetes and renal diseases, to prevent complications and reduce hospital burdens, and ultimately improving patient quality of life. She's an advocate for rational use of antibiotics, and she has led pivotal research on antimicrobial stewardship in Nigerian hospitals and contributed to global discussions on infectious disease management. Her expertise extends to transplant pharmacy, where she coordinates Lasut's renal transplant team, a program recognized internationally for excellence. Dr. Yawole has published on topics ranging from COVID-19 vaccinations to pharmaceutical waste disposal. She serves as an adjunct lecturer for the West African Postgraduate College of Pharmacists and holds certifications in antibiotic stewardship from Pfizer and diabetics care from IDF, that's International Diabetics Foundation, and from bioethics. She remains dedicated to advancing clinical pharmacy practice through education, innovation, and policy influence. So with a round of virtual applause, let's make welcome Dr. Modupe Oyawole.
Thank you. Good afternoon. I think it's still afternoon. Good afternoon, everyone. Can you hear me, please? Good afternoon, everyone. Can you hear
Yes,
me?
ma'am.
Yes,
Can
we
hear
can
you.
hear you, ma. We can hear you, ma.
Okay. So let me try and share my screen first. Okay. Can you see my screen?
Yes, ma'am. We can see your screen.
So yeah. Sorry, trying to move it. So screen. Sorry, don't know why it's not moving. Okay. So sorry. I'm just wondering why the slide is not moving.
Ma, can you try resharing it?
Okay. Let's stop sharing and share again. I've done that now. I've done that. Is the slides that is not moving? I don't know.
Okay. Have you clicked on it first? Then you click on it first, then move it with your keyboard.
Yeah, that's what I've just done.
Okay. Can you send it to me on WhatsApp so I would?
No more. No more.
Okay, I should send it to you. Okay, so let me quickly send it to you because I've already clicked on it and I don't know why it's not sharing the.
Okay, ma, can you try sharing the entire screen? Hello, ma.
Yeah.
Okay, can you try to share the entire screen?
Can you see the screen?
No, ma'am. You can't see your slide.
This is the entire screen. Can you see it?
Okay, we can see the slides now.
Yes.
Yeah, but it's just to move it. For it to move itself. Let me share it. Let me send it to you. I don't know why it's not moving. Let me just send it to you now. I tried it earlier, I was moving. I've sent it to you. Has it entered?
Not yet.
It's to Chris again, you. Or is it
Yes,
WhatsApp?
ma'am. I'm
Yes.
still waiting for it.
Okay. But it has dropped. I don't know. Maybe WhatsApp.
Okay.
Yeah, you still haven't seen it.
Okay, I've seen it.
Okay. Because you just stop sharing here.
Yes, ma'am.
No, you want to show me the window. Okay, should I click on it? Well, I've seen it. Should I click on it? Are you going to be changing it from your end? Hello? Hello?
Yes, I can hear you. I can
Okay, are
see
you
your
going to be
screen.
changing it from your end? Yes, I can see it. Are you going to be changing it from your end?
Yes, yes, we will.
Okay, because I still cannot change it here. Okay, so good afternoon, everyone. Yeah, we're almost going to evening. Thank you for staying on the call. Okay, so just as so Dr. Yawale, I'm a pharmacist, endocrinology, nephrology, So that is the that's my focus. Let me put it that way. Endocrinology, nephrology, that's my focus. Okay, so we have had a really beautiful presentation. Thank you so much to tell that, and I think has been able to tell us about the pathophysiology of diabetes, and also, well, there's no point. I'm not going to go through the incidence, the prevalence, and I'm just going to be looking more about the a kind of introduction into the diabetes without looking at pathophysiology, and then look at the management, and before I zero in on what path that we can take as pharmacists when we're in the workplace and we're dealing with diabetes, when we have diabetes patient in the workplace, how we come in to help them to achieve good glycemic control and, of course, overall treatment outcome. So I have my outline. Can we go? Hello? Okay, so that's my outline. Then next. So as a way of introduction, I'll say diabetes management have evolved over the years, and diverse healthcare specialists, pharmacists, endocrinologists, several people are involved in diabetes. That's one thing about diabetes. A lot of healthcare providers are involved in the management, because diabetes, like I always tell people, is one disease that has to do with the as little as the hair on our head to the nails on our toes, our fingers that is down there. So it means that there is quite a lot that is going on with diabetes, and different healthcare providers are involved, and education is also very important. And one thing about diabetes is that everybody that is in diabetes management space that want to work and want to give the best to the diabetes patient must be a diabetic educator. And that is why we say that repetition is key to learning when it comes to diabetes. That is one disease that every healthcare provider that the patient meets at every point in time reiterates the same thing, because we are all educators. When they say something, by the time another person says it, it seems to ring better. So that's why some things might look like something that the physician has already mentioned, because even in the clinic, that's how it is. You just have to keep telling, and education goes a long way when it comes to patients. Next. High prevalence in the workplace will lead to absenteeism and reduce productivity. And pharmacists is one key member of the healthcare team that play an important role in reducing this trend. That's reduce productivity and absenteeism. Yeah. Hello. Okay, so for me, collaboratory approach to clinical management is key, because everyone defines their role and the responsibilities that we have to take when it comes to management of diabetes patients. Now I'm talking about generally diabetes, managing diabetes now. Everybody has different rules that they take care of, and with all these rules now put together, it goes a long way. Multidisciplinary approach definitely is something that has to come to play every time. And very important, establish communication within the healthcare providers, establish communication with patients and the patients, the patients and even the caregivers of the patient, family members is very important. With diabetes, the family members have to be involved even in their management. Sometimes you insist that they come around so that they know about some of the things that is going on with the patient, because it helps a lot in the journey of the patient, because there are a lot of things that even the patient themselves gets really bothered with sometimes. But when the care providers that are staying with them knows about it, it goes a long way. So understanding the patient journey is definitely very important. Hello. So to manage diabetes effectively, just like the physician has said, there has to always be personalization of treatments. Every patient has different things that they bring when it comes to it. Some will be based on the complications that they have. Some is based on comorbidities that they also have along with it. Some, it depends on even the way they see their treatment. I remember that was a patient that when the patient has to come to the pharmacy, when the patient got to the pharmacy, just sat down and just started crying. Madam, when you bring your prescription, she was reluctant to bring out the prescription. So after a while, we tried to calm her down to and everything. Then she brought out the prescription. After giving out the prescription, she was like, okay, so what is the issue? She said she knows she's going to die soon. So we're all like, where is this coming from? Why do you think, she just felt like since she has diabetes, that she's going to die anytime soon. So it took a while to take time, so that's part of the liberalization that you talked about. At the end of the day, up till now, almost 18 years now, that patient has been diagnosed and she's doing well. So sometimes that first encounter with particular healthcare providers can go a long way in trying to convince them that no, that all you just need to do is to be involved in your management, and this will go away. So every management decision taking will depend on the patient. There are some that think that once insulin is written for them, especially when they've always been on oral, they just believe there is no point even using the insulin. That's just the beginning of them going down and they're going to die. So there are a lot of myths out there. There are a lot of misconceptions and everything. So all these things will be put into place when you are dealing with diabetes patient. Then cost-effective interventions. That's where we come in as pharmacists, actually, because like I always tell people, we can have these high-producing drugs that does wonders and everything is branded and everything. But if after listening for the patient and you're like, this is the only thing you can use, if you don't use it to know, you won't get healed, and although just give impression that that's just the best thing that can happen to you, when you yourself is obvious, and even maybe from interactions, that this patient cannot afford this. So if you insist, the patient will say okay, and it will go. And when it goes home and maybe price the medication, that's or you give the cost, the patient does not buy and leaves and does not buy that medication. What have you achieved? And especially if there are other therapeutic alternatives that the patient could use at that time. So all these can go a long way. So if cost-effective intervention is not put into consideration, when it's not used, the treatment will not be affected. So that should always be behind our mind about it once we do the advice. So it's all about the patient. Of course, a combination of diet. The good thing is that a nutritionist is going to come in here too, and I'll also talk about it a bit later. Improve physical activity. The physician has also mentioned it. Then appropriate medications, very important because of the gamut of things that comes with diabetes when they have it. Then blood pressure, that's their twin. We call it twin. The blood pressure, which will always come, then lipids and regular screening. It's very important for them. Next slide. So, like I said, self-monitoring of blood glucose is one thing that is very important. I remember when we talked to them in the clinic, we used to tell them that sometimes if your parent, because most of them, especially the type 2 diabetes patients, are usually the elderly that are in that range. You tell them that sometimes instead of buying some maybe clothes or some things that you really don't need expected, why not save the money when your children give you this one? Why not save it and make sure you buy glucometer? Because in the past they feel that it's only when they come to the hospital that they really need to check, and some of them will tell you, I don't have money to buy glucometer, never hear looking at it. But when you tell them that if you just put all these bits of money together, is very important, they're going to do it. So they need to be guided. They need to know that this is not something that is just part of the management. It's just part of management. Some of them will tell you that they can always go to maybe a pharmacy around and just check once in a while. But now the part of the point of management, the principle is that everyone that is living with diabetes has to have it. So you encourage them sometimes. And the glycemic goals are also very important. Of course, the very elderly ones, you don't want their goals to be too tight for them. And then for the pediatrics too, there's some that maybe like the baby, the children, the very young children, they sleep early. So you also have to consider how their medications are to be structured so that they can take it early enough. Then also, of course, the management of the complications, which is macrovascular, all this has to be looked into. To next. Hello. Okay, so this is like a summary, because I know that this presentation is more about how we can help them in the workplace. So I might not be going deep into the different medications I use, but I summarize this as the medications that are the common medications that are usually used, up to the recent ones that you find out there. And for type 1, we all know that is insulin, and insulin alone, once it's confirmed that it's type 1. And most times too, diabetes too is type 1. But for type 2, it is the old warhorse, like we call them. That's the very old ones. Some of them are still in use, and that alone is what works for some patients, especially if they are also doing the other things that they need to do. That's where you have your sulfonylureas, which are also called secretagogues, the glimepiride, and that's also the biguanides, which are the sensitizers. And that's where metformin is the main one in that group. Then you have the meglitine derivatives, not as used as they used to be before, but still used. Ripaglitinide, piperglutinide. But then the alpha glucosidase inhibitors too, acarbose, which is not as used as it's not used often like it used to, because of the side effects that we all know. And definitely for the like executives in the office space, it's most times they don't want to have anything to do with it because of the major side effects that can be very embarrassing about it. Then the DPP-4 inhibitors, where you have the sitagliptin and linagliptin. Then also glucagon-like peptide. Those are some of the newer ones, where you have the liraglutide, esinatide, and that's injectable, but has more advantage and some extra when it comes to the use of, though a bit on the eye side, but so patient can still use it. We also have another one, Vitosa. That's the one that's part of the one that the physician mentioned, that sometimes you use like once in a week, bit on the eye side, but if most times the executives in order to, they prefer to use it, so that especially because of the frequency of use, to be able to use it. Then you have the sodium glucose co-transporter 2 inhibitors, SGLT2. That's like the recent ones. And because it has this added advantage of renal protection and also cardiac protection that has been known with it, it's also frequently used now, depending on the cost. And the good thing now is that there are lots of even some generics that are available now that is more affordable to the patient. Yeah, excuse me. So comorbidities, I keep mentioning it, that apart from comorbidities, complications, those are some of the things that makes management to be a bit maybe not as straightforward as it used to be, especially if patients has it along with it. And most of the time you find things like sleep disorders, where some of them will have insomnia, though some of the medications they are on can cause insomnia for some, but some might be as a result of the stress, and maybe also some of them are distressed, and some of them they are depressed because of the fact that they have the diabetes. So some have sleep disorders because of that, and that can be challenging when it comes to management. Also, some have cancers, and some of these medications, the chemotherapies that are used, will even some of them have side effects, just like Zisha mentioned, that can even worsen the diabetes itself. So management can be an issue. Then, of course, obesity, because of the dyslipidemia that usually come with it, and then its own twin, hypertension. It's also so those are some of the common comorbidities that can make the management a bit challenging. But then it also depends on the patient. It's just to personalized, and they know how to juggle. And as pharmacists, that's how we help the patients to situate whatever it is that is going on with them. We come in with advice on the best medication when they have it, because at that point, because of these comorbidities, that's why sometimes some of them are on medications that are really they have the pill burden can be a challenge to them, and that's why we come if there's some medications that they can combine, like we said, that comes in combination. That's what we introduce to them, especially if they can. So it makes the pill burden to actually reduce, and then the ones that needs to be separated, to avoid interactions and all those, to give gap in between, and some that the particular medication has to be changed, and that's just the reason why we keep saying that individualization of therapy is very important. And as pharmacists, we come in to help with the medications that they are placed on after we see them in the pharmacy when they present their prescriptions, to be able to come in and make the necessary intervention and meet with the physicians to be able to arrive at what we think will be the best medications. Everything is about the patient. Let's move. So, like I said, the comorbidities in blacks, management, RAS, calcium channel blockers, among others. And then for the dyslipidemia, statins, and for ones that have comorbidity of renal disease, SGLT2 will come in place, though it also depends on the EGFR that you're looking at. If the EGFR is really low, like 15, like 20, it might still not, might not be the best drug to use at that point in time, because it can worsen. And the major side effect, which is the UTI, can become an issue with that. So it also depends on the renal function of the patient at that point in time. Then the GLP-1 too helps also in renal, and especially if the patient has comorbidity of renal diseases. Then for cancer, like I mentioned, the chemotherapy corticosteroid regimen may be required when the patient is on it. Okay. Hello. Okay, so I just brought this in so that some of us will know about some of the emerging trends in the management, some newer, I won't say medications, but some newer methods that people are looking at when research is still going on. They started using in very little population, but just to, well, it's because as pharmacists, they just know about it, because the way our patients are structured now, the information out there is so much because of the tech space and everything. So anytime anybody can come in, that's where you have the nanotechnology, where the nanoparticles are used to do targets to take drugs, especially some of these drugs or insulin itself to the particular sites where we feel the patients will need it, especially in the liver where you have most of the glucose stored. So you have nanoparticles being targeted to that place. So they're still using it, and it's also used for diagnosis. Then there is also what we call gene therapy. For the gene therapy, what they're trying to do with it is to use it to manipulate the some of the genes that are being implicated, especially for a patient that has genetic, maybe because they have parents that had it before, especially for type 1. So some of the genes that have been implicated as causing or helping for the for islets to be good to prevent it from producing insulin. So sometimes they take some of these good genes, so to say, that does not have that. After removing the other one, they use it to place it to it, and this helps with that. So, but just little population is being used for now. So, but something in the offering, so that in case anybody asks you, it's still about using the DNAs to get that. Okay, yeah, let's move. So now I have some few slides to really talk about what we do in the workplace. For pharmacists, the major thing that we come in to do in the workplace is education and support. So, like I've mentioned, we'll help to tell them about glucometers, insulin administration. That one is very important, because sometimes you find that some patients, because they have changed their drugs, they have changed their insulin, maybe from injectable to the pen filled, it might be an issue for some of them. And this is why for in the workplace, for staff that are into that, really what I think should be to advocate that every workplace, especially by the time you're having like 20, 30, 40 patients, 40 employees, sorry, it is better that as they're coming in, maybe just like we fill some health forms, though in some clients you find people not really reporting it, not putting everything the disorder that they think they have, not putting it in a form, that the health form that you're supposed to fill when we resume. But on the serious note, if it is usually filled, that can be collated. Somebody in the personnel departments can have this, can have the names and the picture of this kind of people, and that way the medications that they are on, you can make it possible that there should be, just like we have hospitals, should I say schools, just like it is compulsory for schools to have like a clinic, no matter how small. When you have a workplace where people come to, adults, there should be like a clinic. If the particular workplace cannot afford to set up a clinic, they should be affiliated to a clinic that is close, where the workers that are diabetes with chronic, because that, I mean, it's chronic disease, and is not communicable anyway. So it should be something that should be disclosed. If at that point it's already disclosed and somebody is already, because there is, in other clients, you have what we call management partners. So when you have management partners, you have a situation that you have somebody in that is making sure that the people that are in the that have non-communicable diseases, especially chronic disease, that they get their break, because we have to release them sometimes to go for their clinic, so that it won't look like they're being there. So you have an idea of when they are clinic, when they have to go for clinic, have an idea of the kind of medications they are on, so that if there is a clinic within the workspace, that the medications they have will be part of what will be always make sure that are stocked. So these are some of the things that you do about it. And when they come, it has to be done. So it's not all about just maybe having physicians and nurses in such clinic alone. A pharmacist must be there to also help them to look at their medications when they come in, monitor whatever I think is going on with them. Because you find out that some of them, when they are with the physicians, they're so overwhelmed, and along the line they forget some things. Sometimes it's when they now come to the pharmacy to collect their medications that they remember, and they'll tell you, hey, I actually wanted to say this, and it might just be something that they're able to do about, or you might even go to the physician to tell them, oh, this person told me about this, and you hear some of them say, but they didn't even tell me, and that might go a long way in some of the decisions that would be made with it. So, and of course, always make sure that there is glucometer for people that want, for the workers that need to buy. Then promoting a supportive workplace environment to ensure optimal health dietary guidance, like food prepping. So food prepping, what I mean by food prepping is instead of having to quickly make their own food in the morning, because just like physician says, some people go from two extreme ends of the where they are staying to where they are working and all this. So over the weekend, it might be that you just prep food that you can just pack that are already in small packs, so that during the week it's easier to like carry it. And even some vegetables like all these carrots and you just make like a small salad. It's packed already, so such things will just be carried along with the food as you're going. That's if there is no canteen that is stocking healthy food. So this is something that I feel that will be done also. Then of course also help with improved communication, just like I mentioned, that if there are issues, then you can now help them to see, to bring them along to see the employers and be able to talk about it. And also with co-workers, it might be a co-worker that is also with diabetes that we need to put together. Sometimes when people are going through the same thing, they find strength in each other, and they take each other along and be able to help people do things. But of course, most importantly, you let them know that there's some things that they need to get clarification and confirm for next. Hello. Okay, so like I said, I've mentioned this before, that we encourage employers to integrate pharmacists into operational strategies within Tutu and to leverage the workplace to achieve better glycemic control, to reduce hypertension and overall well-being, like making sure that they do their tests, check, but I said by the time they check in the morning before leaving and come back and check, that will go a long way. Maybe they just feel funny or something. If there is a if there is a clinic around, you can always go there and then get quickly checked there, or maybe somewhere in the place, in the working environment, can create like a small space that people can go to and be able to like check, or maybe inject when they need to do that. Hello. So I mentioned this before too, that stocking and dispensing medication that is tailored to the needs of the diabetes worker. So if the management already knows about it and they have like a list of the medications that they are on, that's if they do the proper documentation and everything. So we always make sure that the pharmacists stock such medications so that they don't run out and they're good to replace, especially to also make sure that they are always on, that they are not the type of people that will not be doing health insurance. With that co-pay thing that they need to do, their health insurance will be there, and any medication, if there is any of their medication that is not part of the medications that the insurance is doing, then the management should see how, if they have to make sure they buy it or maybe subsidize to maximum, because I mean a healthy workforce, it's a healthy workplace at any point in time, and at the end of the day it's also to bear, so they can always subsidize a lot if there is medications that the patients will need. And also to stock, especially because of hypoglycemia management, to stock glucose and related products that can be used to do. And very importantly, I would like to say that those are part of the things we're talking about, educating them to know how to recognize hypoglycemia. I remember there was a case of one of our patients then that used to come, and everything, because of the education we gave patient, he came in one day and was like, thank you. Hey, do you know that I had hypo? In fact, he used to just call, he wouldn't say the total, he just say hypo. I had hypo, and do you know, because of that, I had to skip the next dose, and because of that, when I checked again, and after eating, I now use my drug. We now found out that what was happening was because he was saying that he doesn't want to gain weight, so he was using the drug, but at the same time was really not eating. And so there's quite a lot of education that needs to be done, and there's what we call hypoglycemic unawareness. So if they have partners or we have co-workers that knows about some of these their condition, even if they go into hypo and they are in hypoglycemic unawareness, which means that the the diabetic patients can go into hypoglycemia and will not even know that already. Might just fall, will become weak and just maybe fall down or start sweating or something, even before the person is even well on his own. But if the co-workers already knows most of these things, they will be able to know. So those are part of the things that we need to come in when it comes to next slide, please. So on physical activity, as already talked about it, stress management, to walk as often as do exercise in between, and monitor and how to evaluate their SMBG result. That's self-monitoring of blood for their result, how to do it. And then as pharmacists too, some of them, especially when we feel that this person is not meeting up with the numbers and is always having hypo. So such people will just make sure that we follow up with them and then be able to help them to achieve that glycemic control that they need and be able to make them feel better. Next slide. So I just put this there for us to know that there are 7 key areas. A kind of summary of what we're talking about is LD, the physical activity, medication taking, not just medication taking, but right medication taken at the right time. All the 6 means of medication taking should be put into consideration and should always know about it. And it will help to monitor them and follow them up. Problem solving, how do they solve problems that will come even before they come to the hospital? Anybody that is empowered and knows about to be able to take informed decisions at any point in time, and coping strategy, healthy coping strategy, and then reducing risk around them for them to be able to do. And that's where you talk about them checking for the that is what we call podometry, to check their legs, check their feet and the thing, so that if there is any neuropathy that they're feeling, we'll be able to avoid a situation where they would now get into a hepatic pain that might lead to amputation. Next slide. So additional rules, we identify at-risk employees doing health talks. Health talks is very important. So even as pharmacists, some maybe it might be that just that if it's like once in a week, go to the have like a day where all the workers will be, and then all the healthcare providers talk to healthcare providers that are around or that will be invited to talk to them, even if it's just like 5 or 10 minutes that you use to talk to them. And in that process, you find that's when they say, okay, some of these things you mentioned have been having it. It might be that it's a different thing that they feel they're going. But when that health talk is like a general health talk for everybody, some people will pick, and from there, some will tell you that they are having some of these things you're talking about. And then from there, you can identify at-risk employees that have that, and then to help promote preventive measures. And to also tell them the immunizations, especially the ones that are elderly, some immunizations that would prevent them from having that can help to delay their delay complications for them. Any immunization schedule that they're supposed to have, like the pneumococcal vaccine, influenzas, and all those needs to be done just to prevent them having some of these comorbidities that come. Next. Hello. So proper storage and administration, very important. That's part of what we tell them during health talks, how to store properly, and especially the ones on injectables, the insulins, and even the ones on tablets, cool dry place, having a purse. That's what we tell them. You have a purse, and then you arrange the medications they are based on how you really use it, and you make sure that it's not something you throw around. So how they have to do it, and for the ones that do Africa, and of course telling the management that for the people on insulin, there has to be a fridge around. So, and that's not the fridge to put all sorts of things, such that somebody now removes it and puts it where it's not supposed to, maybe close to the fridge or close to the freezer, or somewhere that is close to the back of the thing, or maybe alternatives to even how to store the insulins. And so all these things are very important, how they store them and at home especially. So, and then very important on reporting potential drug interactions and adverse effects. So if there is anything, keep telling them there's anything you feel after you take your medication or around the time you take your medications, document it, write it down. Just like we ask them to document their readings and the kind of food they eat around that time, those things. So this, most of the time, exercise books are provided, and they bring this thing, and it helps to know what is really going on with them. Maybe it's the food they're taking about that time, instead of just increasing their dose. Maybe it's just the things they're just doing. So just use the opportunity to refer them appropriately. Just maybe let the physician know, and then you can refer them to the nutritionist to be able to do. And documentations of drug therapy problems and reporting appropriately adverse events and everything, whether online, yellow form, and go. Next. Okay, so I just use it as a tidbit to tell us that pharmacy's roles has changed over the last 50 years from just dispensing, especially when it comes to chronic non-communicable disease. Interventions that do now address medication effectiveness, safety, tolerability, adherence, and affordability. Literature is watched with works done on pharmacist-led diabetes care, as we say. Next. So, thank you for listening. Let's interact. Thank you. That's all.
Thank you very much, Ma. That was very insightful. That was very insightful. Thank you very much for building on the knowledge that we've already acquired. Finally, I would like to welcome our final speaker for today, Mrs. Sherese Ijewere, a clinical nutrition consultant, to share more insights on diabetic management in the workplace. You're very, very much welcome, Ma.
Okay, thank you, everyone. Thank you for having me. I would like to indulge and just have everyone get up and stretch, because I think we've been on this for the last almost 2 hours. So if you've been sitting down, take a moment to stand up, stretch your back. 2 moments, side to side. This is one of the things that we also make sure that we teach our patients, that we should be in movement, constant movement as much as possible. So I'm going to go ahead and share my screen in the meantime. Okay. Just give me one moment. Are you seeing the presentation as yet? Has the presentation come up?
Yes, Ma, we can see the presentation.
Okay, so integrating diabetes care into daily work routines. My name again is Sherese Ijewere. I'm a clinical nutrition consultant, a gut health and lifestyle medicine practitioner. And I thank my colleagues, Dr. Akinlade and Dr. Modupe. Really appreciate the insights. You've kind of made this part of the presentation much easier for me. I know Dr. Akinlade spoke about knowing your numbers. This is very important, that clients are following up with the multidisciplinary team, from the endocrinologist to, yes, the pharmacist, but especially the nutritionist, and just checking in so that they know they are on the right track. Having their own blood pressure monitor, their glucometer, and then also measuring their weight or keeping this in view. Now, we know the father of modern medicine, Hippocrates, and his teaching long ago was all disease begins in the gut. And so this basically means that there's a bidirectional relationship between the gut health and diabetes. So there has to be a mindset shift for the patient, what they're eating, connecting, being mindful on all the different habits and their day-to-day activities. In diabetes, this link involves specific changes in the gut microbiome, which is the home of where the bacteria lies. And this can contribute to inflammation, insulin resistance, and of course, autoimmune responses. So in the gut microbiome, of course, you have trillions of bacteria, fungi, so much going on in the gut. And so diabetes can affect the gut. Whether it's high or uncontrolled levels can damage the nerves throughout the body, including the GI tract, which then leads to things like slow digestion, gastroparesis, constipation, diarrhea, bacterial overgrowth, and really unhealthy bacteria thrive here. So eating for the gut microbiome. And some of the impacts that the gut has on diabetes and just the overall body is energy levels, brain function, mental health. We often get complaints that some diabetics and even some non-diabetics actually start forgetting things, whether it's from just their poor diet, their poor lifestyle, and just tuning really into the foods that they're eating and what they're not eating. Of course, the gut also impacts the immune health, the thyroid function, the hormones, sleep quality, chronic physical pain, skin issues, and of course, the list goes on. So one of our key teaching for our patients is really helping them understand food, what it does for the body, and how it plays out in nutrient absorption. So let's look at what destroys our gut microbiome. Of course, we know stress plays a huge part along with the foods that we're eating. And so we do our best to teach some relaxation.
Sorry to interrupt, ma.
Yes?
Your slide is not moving.
Okay, at all?
No, ma, it's not moving.
Okay. Okay.
What do I do now?
What about now? Are you seeing?
No. We can see the slide, but it's not moving.
Okay. Okay. Well, let me stop sharing and then let me try again. That's really
I have to try Windows and try
really strange.
So it's already down, already here.
Show my
Okay.
You have to do
What
it
are
with
you?
the left. What's the
Okay, we can see it now.
touching it?
Okay, but let's see if it will move. Okay, so this is the gut microbiome slide with the trillions of bacteria and fungi and protists. Has it moved now?
We can see the slide, but can you try
Okay.
moving again?
Okay, I've moved it.
No, it's not moving.
It's not moving. Okay, all right. Give me a moment.
Maybe if we move it to presentation mode first.
Yeah, that's what I had it on.
This is-
Yeah, that's what I had it on. Can you see this slide now? Has it moved?
No, not yet.
Okay, so let me try something else. Give me just a moment. Okay. Okay, just give me a moment. No, mine is not cooperating today either. So let me see if I can send you my slide then. Okay. Mm. I would need you to send me your WhatsApp because I don't have that contact, I don't think.
Oh, all right. You can actually just send it to the mail.
Send it to the mail. Okay, let's see if it will attach to the mail. Let's see if I can. Okay, I may have to log out and log back in. So it's not responding.
All right.
Mhm. So let me do that really quickly. Okay.
All right.
Okay.
All right. While we're waiting for our next speaker to rejoin, if you have any questions, you can actually start dropping them in the chat box so that we can take questions after this session. Good evening. Okay. All right. You can type out the questions. If you have any other questions, just put them in the chat box. We'll take them immediately after this speaker, and then we can round up for today. Okay, while we're waiting for Mrs. Sherris to rejoin, I'd like to take a moment to speak. Okay, I'd like to take a moment to briefly speak on our brand of metformin, which is Emzophage 500. Let me share my screen. I'd like to briefly speak on our brand of metformin, which is Emzophage, as you can see on the screen. So Emzophage is locally manufactured by Emzo Pharmaceutical Limited. And of course, it's a high quality formulation of 500 milligram metformin hydrochloride for management of diabetes. And hopefully, as we leave this meeting, we will keep Emzophage top of mind when it comes to diabetes care, diabetes management, because it's a high quality, locally manufactured metformin that is affordable for most patients. When the pharmacist was speaking, Dr. Oyawole, she mentioned that sometimes patients leave without getting their medications. And one of the reasons for that is that a lot of times the imported medications are highly unaffordable, they're very expensive. So Emzophage is a locally manufactured, high quality, affordable alternative that you can recommend to your patients or recommend to people that are currently managing diabetes and are unable to afford their medications. It's the first line treatment for management of type 2 diabetes mellitus. And I hope we keep it top of mind moving forward. Okay, we're still waiting for the third speaker to rejoin. Nonetheless, I think we should just take, put out all the questions so that once she's done, we'll take the questions and round up for today. Okay, I can see some questions in the chat box already. Okay, Dr. Akinyele has responded already. Dr. Akinyele has responded already. If you have any other questions, just put it in the chat box. All right, so welcome back, Mrs. Sherris.
Okay, thank you so much. Thank you. I'm so sorry about the break in this sharing. So I will just get back in if that's okay. Is that fine?
Yes, Mama, we can see the screen now. Can you try moving it?
Okay. How is it now?
So it's still not moving, but
Okay. Still not moving.
Can you click on the slideshow at the top right?
Yeah. So it's not even allowing me to.
I also sent you my WhatsApp number. I sent it to your mail, so you can send it to me on WhatsApp and I'll share it.
Okay. Okay, let me do that. Even try if this will. Are you seeing anything now?
No, we can't see the screen now.
Okay. Just 1 moment. Okay, how is now?
Yes,
Anything
I can.
moving?
Can you try moving again? Okay, yes, it's moving
Yeah.
now.
Okay, all right. So sorry, everyone. Just to get right back into it, the things that destroy your gut microbiome, I mentioned stress, and stress management is so important. One of the things that you want to ensure is that you are giving your patient empowerment, which means that they have to own what's going on with them. And so if you have your multidisciplinary team that includes, yes, your doctors, you include your mind body coach, because a lot of a mindset shift has to occur with the patient. And so just asking the patient things like exercise, hobby, what's their motivation? Do they meditate? Do they go out in nature? Or are you in the office all day? Because that sometimes is a big part of the issue. We've become sedentary people in the office for 80% of the time. We're spending 8 to 10 hours outside of the home and fewer hours inside the home or even on self-care. So time management is key. Helping your disciplinary team take charge of the time management, and as the other doctors mentioned, really understanding that person's lifestyle. And it has to be the mind body coach that does that, or maybe the assistance of the nutritionist, because the doctors are busy, the pharmacists are busy. So each person is able to work together. Of course, encouraging your patients to stay away from sugars and artificial sweeteners. I find that quite a few patients may be on the 3-in-1 coffee. This poses a problem to the microbes in the gut. Also, just reading ingredients. Empower your patients to read ingredients. If they are going to the supermarket a lot, take time to look at what they are buying, because these manufacturers of the so-called food are putting the information on the packet. It's just left for us to read it. So we are taking responsibility for our health. And as nutritionists, we do encourage our patients to go to the market. Sometimes we will have our assistants maybe help them with grocery shopping, meet them at the market, explain to them the colorful foods that are important, the natural foods that we have. Many of the diabetics, especially with being busy, just forget that you can actually eat natural foods. Our culture in Nigeria really harnesses on the natural foods that we have. So our ewedu soup, our amala, our sweet potatoes, plantain, we have nutrient dense foods. But because we're so busy, we're going to the convenience of packet foods, which is a problem. So we must ensure that our patients see this mindset on how they're looking at food. What really is food? Are they going to the eateries all the time? Taking the burgers, the chicken that has been rolled in flour, all of that can also cause inflammation into the system, causing elevated blood sugars, and of course, stressing the immunity. If they are also taking certain medications, this also poses a problem. the chewing gum here and there, the diet colas, all of this is explained by the nutritionist, taking time, and not just a one-time consultation, but 3, 4, 5 times within a certain period, just to ensure that the patient is understanding and working hand in hand with the team. We really put emphasis on the processed foods, those quick things that many people have at your desk. So whether it's the plantain chips or the biscuits or maybe the sweets, this is really not the answer for the low blood sugars either. So having that diet plan, the meal schedule, and then ensuring that when you're going to work, you're not depending on the cafeteria, but you're taking responsibility by packing your lunches. This can be done with time management. Pack your lunches, pack some fresh items. And once you get in the rhythm of things, then you know that, okay, I'm taking my break time at a certain time, I'm having my lunch at a certain time, and the employer understanding this from the beginning. We also teach about avoiding artificial seasonings, the cube seasonings, because this can sometimes cause one to overeat. Alcohol plays a humongous role. So it's not having even one glass, but really being upfront with the patient that alcohol destroys the gut microbiome, which also affects the blood sugar, affects the sleep, causes stress. It just causes a cascade of issues. As much as possible, just educating your patient and empowering your patient. Once they have knowledge, then they can make their decision. Health is by choice. So being proactive, knowing that one size doesn't fit all. Customizing a meal plan is what the dietitians and nutritionist does, and building lifestyle modifications and goals for each patient. Really having that sit down, take your time, talk with the patient. Supporting the patient by helping them with understanding what intentionality means. Of course, the being aware, doing things deliberately, consciously, on purpose. Have your patient be responsible for what's going on. It's not about the pill. Okay, so water intake, of course, critical. So each person should really have their own designated water bottle, whether they're diabetic or not. Everybody should have their own water bottle, and it's not the plastic bottle. This could be a glass bottle or a stainless steel bottle. And throughout the day, whether you need to set a time on your watch or on your phone where it buzzes and that prompts you to drink. So sticky notes, whatever it takes, one has to be responsible for that. Supporting herbs for the gut microbes, the turmeric, the ginger, these are things that really help to reduce inflammation. Miracle leaf, sense leaf, cooking with oregano, thyme, and planning your meals ahead. This helps tremendously. We've put a lot of diabetic patients, their diabetes in remission in our clinic. So we're quite proud and happy to help patients understand and recognize what they need to do day to day. Eating more alkaline foods, from the vegetables, the colorful fruits, and helping them understand what's low on the glycemic index, what's acceptable, what's high on the glycemic index. And of course, yes, helping them to recognize the foods that are organic, or plugging them into the organic farmers, the organic farmer markets. All of this is very much available. And of course, things such as prebiotics, really having those fibers feed the microbes in the gut so that one can absorb easier and make more nutrients for energy and for just healthy living in general, for the gut as well, and for digestion. Fermented vegetables such as sauerkraut, kimchi, so many of these can be taken right before your meal in order to help rebalance that gut microbe. Now, looking at proactive food swaps, when we educate patients and counsel patients, we're also giving them practical examples. So instead of bread, it would be go for the grilled sweet potato. Make sure there's vegetables that is with these items. Inflammatory foods such as biscuits can be switched out for certain fruits, low glycemic index fruits that are in season. You always want to eat what's in season. Instead of using dairy, of course, you can use plant-based milk. You can also stick with our natural ogi, the millet ogi, put some ginger, put some cinnamon, those things that will enhance the immune system. And helping them see that all of this is very doable, very practical. Processed foods, really eliminating the processed foods, processed meats, whether it's the shawarma, the hot dog, and helping them see that there is an alternative, the grilled fish, the chicken, taking these items and planning ahead. And of course, if there is a cafeteria, those can be put in the cafeteria as well. Most of all, eating variety, eating in season, and eating as local as possible. These we know are quite affordable and good for our patients. So supporting with meal balance, helping with natural fibers, the lifestyle, and then of course improving the immunity. And this can be done through strength training, cardiovascular, flexibility, balance, just giving them as much knowledge as possible. And so they can also keep a little journal so that that journal helps them to be accountable to what's going on. Because at the end of the day, we truly can't just function like we're robots. You really have to be in tune and take a step back and look at what's going on. Sleep is very important for repairing your cells, rejuvenation, just helping your body come back into balance. And of course, when it comes to sleep, encouraging that 7 to 8 hours of sleep daily. If they're having trouble with sleeping, insomnia, that's when we look at nutrients that may be missing. Maybe they're having underlying deficiencies. And so once that's corrected, you sleep like a baby and blood sugar usually is balanced. So in summary, genes load the gun, lifestyle pulls the trigger. So for us to empower our patients and give them all the knowledge they need and then follow up with them frequently is what's key. Thank you very much. Thank you, everyone.
Thank you very much. Please, can we give Mrs. Sheris your round of applause? Thank you very much, ma. That was very insightful. That was a very unique, important, and highly relevant perspective on management of diabetes in the workplace. All right. Right now, we'll be taking questions. If you have questions, you can either raise your hand or put them in the chat box. Some have already been answered. So if you have any more questions, kindly raise your hand or put your questions in the chat box. Okay.
Yes, 1 minute.
Does anyone have any questions for any of our speakers? Okay, she said her question. Okay, Ngozi Uzokwe. Ngozi, can you put your question in the chat box?
It's 5:21.
I'm trying to do that, but what this thing?
Ngozi, no need to put it in the chat box since you have permission to speak. Okay, all right. Okay, seems like the question is for Dr. Akinyele. Dr. Akinyele, please, would you like to go ahead to answer the question, or should we take all the questions and then you can address them?
Well, I'm trying to read the question so I can. So fasting blood sugar level is not just in the morning before food, from the first speaker's definition, eating in the morning and checking around 8 p.m. Yes, the important thing is that the person must have fasted for at least 8 hours, usually 8 to 12 hours before you can qualify. And that's why, for example, during the Muslim fasting period, because the Muslims wake up early in the morning to eat, so for them to check their fasting blood sugar, it should be done if for example, the meal was concluded around 5:30 a.m. So it means that by around 4:30, 5, 6, once they check their blood sugar at that time, it qualifies for a fasting blood sugar. So you're right. But the person must not be over fasted. So the window is usually between 8 to 12 hours of fasting. I hope I answered the question.
All right. Okay, she said you did.
Yes, sir.